Hello, I'm Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance. I'm an associate professor at the University of Washington. I'm the clinical director of the Genentech Cancers Program and also associate member at the Fred Hutchinson Cancer Research Center. I'm very excited and thrilled today to discuss with my good friend and colleague, Dr. Shilpa Gupta from the Cleveland Clinic.
Hello, Petros. I'm really excited to be here with you to discuss the abstracts from GU ASCO. I'm Dr. Shilpa Gupta. I'm a staff and genitourinary oncologist at the Cleveland Clinic in Cleveland, Ohio, and leader for the bladder cancer program.
Shilpa, wonderful to talk to you as always. And we had a really fantastic ASCO GU 2021. Despite being virtual, it was very, very exciting, meeting great data. So I would like to talk to you about some of the examples of those amazing results and interesting data presented, specifically for urothelial cancer. And I will start our discussion about the non-metastatic setting of urothelial cancer. We saw the updated data from the POUT Adjuvant clinical trial, randomized phase 3 trial in the resected upper tract disease, upper tract urothelial cancer by Dr. Alison Brittle from UK, showing that adjuvant platinum-based chemotherapy prolongs disease-free survival compared to observation in this setting. And we have seen the data before from previous ASCO GU, and now the paper is published. Any comment you have about this setting? It shows that the disease-free survival benefit is sustained with longer follow-up, but the overall survival benefit had a trend, but did not reach statistical significance, but probably was underpowered because of the premature closure of the study. Any comments, and how did that influence your practice?
No, I think this is a great endeavor to run such a study across multiple centers, and the data is very promising, although I will say that cisplatin-based chemotherapy conferred a higher benefit as compared to carboplatin chemotherapy. So certainly patients who can get cisplatin after nephroureterectomy, given the caveat of a solitary kidney and impaired renal function, it's not always possible. But if they can, this data is compelling, and we use cisplatin-based chemotherapy when possible.
Important points, and I always think about the primary endpoint in adjuvant trial, and I think the context you put here is important because we also have a very important abstract from Dr. Dean Bavarian and colleagues, Dr. Galsky and others, looking at the adjuvant nivolumab versus placebo in patients who had resection of the primary tumor, bladder or upper tract disease. And this randomized phase 3 trial, adjuvant nivolumab, appeared to prolong disease-free survival compared to placebo in this particular study in patients who either received neoadjuvant chemo and had PT2 or higher stage, or patients who did not receive neoadjuvant chemo and had high risk of recurrence. So it's interesting now because we have two trials showing disease-free survival benefit, but no overall survival benefit by statistical, significant statistical rigor. So what's your take on the CheckMate 274, and how does this influence your practice in the context of the POUT trial?
Yeah, I think that's a great question, Petros. With the CheckMate 274, it allowed neoadjuvant chemotherapy, and that was for bladder cancer as well as upper tract cancer. So more inclusive for what we see in our routine practice. I thought the data was really interesting, improvement of disease-free survival by about 10 months. However, the overall survival was not yet reported, so it's difficult to say what it will be. Especially in the PD-L1 positive population, it conferred a higher disease-free survival benefit as compared to the ITT population. I would say that is a great data, especially because our practice is to use neoadjuvant chemotherapy for patients with bladder cancer as well as upper tract disease. We at our center use a lot of neoadjuvant cisplatin-based chemotherapy. And if after that patients have a high risk of recurrence, nivolumab could be considered if it were to get approved in that setting. So I think both these studies really bring out the point that disease-free survival, if sustained and can produce overall survival benefit, is something we should be willing to adapt in our practice.
It's interesting because I remember in the ASCO virtual meeting, there was this discussion, the plenary session in an adjuvant setting of non-small cell lung cancer, with osimertinib there, and I think it was the ADORA trial, if I remember, and there was a big right? In the lung cancer community, do you adopt, adjuvant therapy based on DFS benefit or wait for OS? And I think this debate is still on in urothelial cancer, to your point. And, personally, I conceptually, philosophically, I would like to see overall survival benefit in a trial done in the adjuvant setting when, you don't have visible disease and you have potential toxicity and considerations. The question in my mind is, what is the likelihood of disease-free survival corresponding to overall survival benefit, especially with the CheckMate 274, because we don't have this surrogacy data in the immunotherapy adjuvant setting. However, as you mentioned, the hazard ratio is very impressive, especially in the PD-L1 positive patients. However, if you look at the particular Kaplan-Meier curves, especially with the non-urothelial tract recurrence-free survival and distal metastasis-free survival, the tail of the curve, the two curves come close. So I think it's interesting to see whether with longer follow-up, this will translate to overall survival benefit.
Yes, and I think putting things into perspective with so many effective therapies that have come around in the salvage setting, which we'll talk soon about, we have to see how much benefit we are really conferring by using these adjuvant therapies without an overall survival benefit.
Absolutely, and just to circle back on the POUT trial, also important. It was interesting because it was closed prematurely and it was probably underpowered for overall survival. The question I have for you is: you have a patient in the neoadjuvant setting who is fit for cisplatin, and you're worried about the disease that being potentially high risk, and we have the potential risk of understaging in upper tract disease. Do you consider this patient for neoadjuvant cisplatin-based chemotherapy? We have some phase 2 trial data from the ECOG-ACRIN trial by Dr. Hoffman-Setzic. Would you do that, or you would do surgery first and then adjuvant chemo if possible?
That's a great question, Petros, and I think when possible, we should try to, and I personally try to do that because patients have 2 kidneys prior to the surgery. The chances of them becoming renally impaired post-surgery with a solitary kidney is much higher, in which case we cannot give cisplatin-based therapy and have to either resort to carboplatin-based therapy or surveillance.
I agree. I agree with you, Dr. Gupta. I try to give neoadjuvant cisplatin-based chemotherapy based on extrapolation from bladder cancer literature and the phase 2 trial data in upper tract disease. In the adjuvant setting, we also, I want to highlight, we have 2 adjuvant trials: the Ambassador trial, adjuvant pembro versus observation, and also the Proof 302 trial with adjuvant infigratinib versus placebo in patients with FGF receptor 3 mutational fusion. So both those trials will be interesting to see and follow over time. The last abstract I would like to get your comments, Shilpa, is from Dr. Katomas, the data with perioperative GemCis plus durvalumab in muscle-invasive urothelial cancer, the SAKK 06-17 trial. And this trial evaluated the perioperative role of chemoimmunotherapy in combination and showed some interesting data with pathologic complete response of 34% and pathologic partial response or downstaging about 60%. This data, to me, reminded me of your data from the BLAST-1 trial that you presented at ASCO GU last year, and definitely support the ongoing phase 3 trials. But in my mind, the phase 2 data are not practice-changing yet, but definitely support the phase 3 trial that are going right now, the Niagara trial, Energize trial, and other trials with pembrolizumab and chemotherapy, like the Keynote 866. Any comments on that, and what's your take?
Thank you, Petros, for highlighting our BLAST-1 trial, which was nivolumab and GemCis as neoadjuvant therapy. We saw 66% downstaging to PT1 or less, and 50% complete responses, including CIS. Now, putting this in perspective, this trial is also adding durvalumab in the post-operative setting. So it's a true perioperative trial. And looking at the response rates, it does not seem to add much to what we just see with GemCis, in terms of pathologic downstaging. However, the event-free survival long-term follow-up would be interesting to see. I don't think in this they have reported it yet, but that is the primary endpoint. And there was some concerning post-operative complications that they saw in this study, and long-term follow-up is really necessary.
Thank you, Shilpa. I think these are great points, and we're looking forward for the phase 3 trials. Congratulations on the BLAST-1 study, and I think the current landscape for the audience, the use of checkpoint inhibitors in the neoadjuvant setting is experimental, and I think it's important to accrue in the phase trials that will confirm the results of the phase 2 trials. With that note, I would like to thank the audience for the attention. It was a pleasure discussing Shilpa today, and looking forward for more data in the future.
Thank you, Petros.